Hey everyone, hope you're having a great day. It's that time of the week for our compilation video, and this week we've been talking about issues with American health insurance. Now, we've really been focusing on private health insurance. Kind of state-funded health insurance is a whole nother issue, but we've talked a lot about different terminology, prior authorizations, and then alternatives for kind of private health insurance. So those stories should be up on my Instagram page, and obviously this compilation video takes all of that and puts it together. So, but if you are new to my channel or you're new to kind of watching my content, if you wouldn't mind, make sure you like and subscribe. That really helps me out, letting me know kind of who's watching, what to do, and how best to kind of direct these. So starting off, when you look at health insurance as a whole, this is a very wonderful idea, and really this is kind of a basic human right? People should be able to have health care, be taken care of. And the original idea for health insurance was actually thought up by Teddy Roosevelt in the United States, kind of looking at something very similar to a kind of social medicine type of model. Now, in the early 1920s, a group of teachers in Texas actually ended up petitioning one of the local hospitals there for some kind of mandated, if you will, or kind of set aside sick days. And they ended up getting about a month's worth of kind of prepaid sick days with Baylor College of Medicine there. And this was the very first type of health insurance that we had in the United States. Now, after World War II, you started to see things like Blue Cross and Blue Shield and some of these other companies start to pop up. And the way that these worked was very similar to other types of insurance, in that you would go to the doctor or the hospital or whatever, you'd have your medical care, you would pay for that, and then you would submit that bill to the health insurance carrier, and then they would in turn reimburse you for the charges accrued. And that was pretty much how health insurance was for the majority of the 20th century until we got into the 80s and 90s, and we started to see the advent of a lot of very large managed healthcare organizations. And there's tons of them now, too many to name, and they all have their own little intricacies. But this basically kind of brought around the idea of people paying a monthly premium to have health insurance, paying a fee every month, whether you use it or not. And for some people, this could be, depending on your employer, it may be, as little as $5. It may be as much as, hundreds of dollars. It just kind of depends. And the thought was, okay, because you are paying into this, now you get to use some of this health insurance if you need it. And obviously, if you don't need it, well, then that money goes towards paying someone else who did need it. And once again, this makes sense. Insurance is like this. You pay something every month, and if you need it, you do. And if you don't, that's great. But what really we have seen transpire as the 20th century ended and the 21st century began is that lots and lots of insurance carriers were increasing monthly premiums almost to the point where, your average family couldn't afford them, especially if they were doing, if they were having, like a sole business, they were self-employed. It became problematic until you had tons of people without health insurance. And so the Affordable Care Act, which was put out in President Obama's administration, basically said, hey, here's a means for everyone to have affordable health care. And oh, by the way, if you don't have it, well, you may have to pay a penalty. So each state kind of does their own thing with that. But that's kind of how the history of the organization or the institution, if you will, of health insurance has kind of progressed. Now, obviously, one of the things that we've seen in terms of not only increasing premiums was this idea of a deductible. And once again, this is similar to other types of, insurance things as well. If you get in a car wreck, well, you may have to pay $500 for your deductible, but once that's taken care of, then they cover everything else. Well, health insurance, it's a little bit different in the private sector, and that deductible oftentimes can be thousands of dollars, sometimes even as high as $10,000, or tens of thousands of dollars in high deductible plans. And the other thing is a lot of healthcare insurance companies now are also only paying a portion of your health insurance cost, even after you've met your deductible, until you reach what's called your out-of-pocket maximum. And that is the maximum amount that you have to pay over a calendar year. Now, typically they divide this into an individual out-of-pocket maximum, a family out-of-pocket maximum, and then a medication out-of-pocket maximum. So even though, you went to the hospital and you met your own out-of-pocket maximum, well, that means that maybe you're fine, but if you need medication, well, that's a whole separate thing. And if one of your family members goes, well, that's a whole separate thing too, even though your deductible has been met and you've been paying your premiums every month. So this gets to be a really big problem when you have people that, are basically paying something every month, and then if they are unable to meet their deductible because their, deductible is sky high, they're basically just throwing away money. And this is really what has kind of led to the advent of a lot of the alternative possibilities for healthcare that I'll talk about in a little bit. Now, other types of important kind of terms, if you will, with health insurance include things like in-network and out-of-network providers. An in-network provider is a provider, whether that's a individual, a clinic, a lab, a hospital, whoever, that is contracted with a specific insurance company and has agreed to abide by the policies of that company, and also has agreed to accept whatever that company decides they're willing to pay based off of a service. Out-of-network providers, on the other hand, have not agreed to do that, and so they're not beholden to any of the rules set by that particular insurance company. Now, for out-of-network providers, most commercial insurances will provide a portion of that cost. They'll say we cover out-of-network providers at 50% or 30% or whatever it may be. But really, they're trying to steer the people that are paying their insurance to go to those in-network providers, because then they get to dictate how much that person is charged. And this is something that if you ever look at an insurance bill, they make those kind of purposely difficult to understand for a reason. But, if you go, let's say, to a doctor, say you're sick, and you go in, you walk up to the desk, you say, hi, I'm here, I'm sick, I have an appointment. And they say, okay, well, let's check your insurance. They run it. They say, okay, you owe us a $25 copay. That's basically something that is mandated that doctor's office gets before you can be seen there. And that mandate comes actually from the insurance company. Now, you go through your visit, the doctor ends up billing, let's say, $100. Well, the insurance company says, okay, well, I'm only going to pay $60 of that. I'm not going to pay the $100 because you contracted with me because you're an in-network provider, and so I don't have to pay those others. So that physician typically or practitioner has to write off that additional amount. Now, sometimes some insurance companies will let the provider kind of then charge that extra amount, but that's by no means the norm. And this is why a lot of times providers that take commercial insurance have to have shortened visits and are trying to see so many patients, because not only are they potentially losing income off of each patient because that insurance company is refusing to pay the amount that they've been billed, but you're going to also, it may be 90 days, it may be 120 days before that provider is even cut a check from that insurance company for that specific, visit, which is crazy. You think about it, like we don't really see this in other industries. If you go to a restaurant, it's not like, they say, okay, that'll be $20. And you're like, well, okay, in 3 months, I'll get you that $20, but for whatever reason with health insurance, that's okay. And that gets into prior authorizations, and I'll talk about that in a little bit. Out-of-network providers in that same scenario, you as the patient would get billed that entire, fee of that $100. But what you can do is actually submit that bill to your insurance company. Insurance companies have little forms on their website for out-of-network provider, submissions, if you will. And they'll, require the receipt of what you paid and then also kind of the bill from the provider. But then they will either reimburse you or, that applies towards your deductible or whatever it may be. In that same example, if your deductible had not been met, then you would be up all of that money out of, anyway. So it ends up kind of being a wash for that. So it's really kind of an interesting system. And by interesting, I mean very broken. because of these lovely things called prior authorizations. Now, what you're not seeing behind the scenes is that, let's say in this same example where you visited a doctor, your doctor had to run some tests and said, okay, I want to run these tests. Well, they have to make sure that those tests are going to be approved by the insurance company, or you will get billed for them, and the insurance company will say, well, we're not going to let you do that because you haven't met our prior authorization. We see this a lot of times actually in medications. And PAs, or prior authorizations, were originally made to kind of steer providers towards generic medications as opposed to newer, less generic ones, because the generics were cheaper. But nowadays you're seeing prior authorizations for even just very straightforward diagnostic testing, straightforward generic medications, surgical procedures, whatever it may be. And the problem is this delays patient care by quite a bit. No studies have been done that show that prior authorizations help patients. There are numerous studies that have been performed that show that prior authorizations hurt patients, especially in areas where going without medication can be horribly, catastrophic, like in the areas of mental health or psychiatry. You have a patient that's, let's say, schizophrenic, that all of a sudden, now their insurance says, well, you have to have a prior authorization for that antipsychotic medication, and the patient now is off of it for, a month or two, or however long it takes to go through the rigmarole to get that medication. So it's a very, very frustrating thing. And like I said, all PAs do basically is just kind of line the pockets of the insurance companies, because that patient who is still paying that premium every month is going through there. The insurance company is still getting it. And if they can hold off on paying out for the cost of that medication, then that's more money they get to keep. The other thing is that they may say, no, you have to use one of, these medications here. This not going to ever cover that one medication you wanted. And these medications are a lot cheaper. So then the provider has to try and fight it and go up this whole chain of command, talking to the individual people at the insurance company, then maybe doing this thing called a peer-to-peer evaluation, then maybe submitting forms and all this other red tape that can take weeks or months to do. And in the end, the insurance company can still completely deny it. So it's a very frustrating thing, and it really puts the practice of medicine in the hands of insurance companies. And remember, these are not healthcare providers. They may have a medical officer there, but these are not practicing physicians or nurses or anyone who's actually taking care of patients. They are just taking care of the insurance company. I gave some examples in my story, but I think the one, I have lots more, but the quickest one is, I had a patient that had, a history of sexual trauma when she was younger. She's now menopausal. She's not sexually active. She doesn't, do very well with pelvic exams, but she has this condition called genitourinary syndrome of menopause. And I've talked about that before. But she's having recurrent bacterial infections in the vagina, recurrent urinary tract infections due to low estrogen after menopause. Well, because of her history and her, saying, I don't want to do anything vaginally, I decided to prescribe an oral medication that you can use for GSM that only targets tissue in the vagina. We submitted that. The insurance company denied it. They said, nope, you have to use one of these vaginal preparations. So even though I took the time, I know this patient, I went through her history, she has said, I don't want that, I'm not going to use that. I now have to, document all of that and submit it. And then, I may have to have a peer-to-peer talk, and peer-to-peers basically, in my experience, have never been another gynecologist. I have never spoken with another GYN in doing a peer-to-peer about GYN care. I've spoken with a clinical pharmacist, a podiatrist, a pediatrician. Those are the three main ones that are the most egregious in my mind, because, they're so far removed from what I do. What does a podiatrist know about sexual dysfunction and sexual dysfunction medication? That doesn't make any sense to me. So anyway, prior authorizations, are the bane of the American healthcare system. And it's really just a racket. Like I said, they don't help patients. They don't do anything for patient care. So what are your alternatives as a healthcare consumer? Because that's what they want you to be now. So Outside of commercial insurance, there's a bunch of different things. And I actually had a lot of people kind of respond that, I didn't know this was a possibility. So you have direct care, which is both divided into DPC or direct primary care and DSC or direct specialty care. In this care model, you usually pay a monthly subscription fee. Usually on average, it's $70 in the United States. And with this, you have unlimited office visits with your provider. Often labs and imaging studies are either covered with that cost or are contracted to specific institutions that give it at a significantly discounted rate. You get to spend extended time periods. The average patient visit with these providers is at least 30 minutes. Counteract with the average patient visit with a commercial insured provider is 7 minutes. So that's quite an extended period of time, but it's not uncommon to see 45-minute or an hour visits. We have close friends that use direct primary care, and they've said they spend hours with their providers because the provider has the time to do that because they're not going through insurance. The patient basically is paying the provider directly with that kind of monthly fee. These monthly kind of subscriptions can be canceled at any time. You're under no further obligation. It's really just kind of a month-to-month type of thing. I have a colleague that does this, and down in Texas area, and she told me some of her labs. She will draw the lab in her office and then bill the patient with that. She said for some of her hormone labs, it's $4, $5, $6, $10. Whereas if you go to a lab and you actually get it through your insurance, you may get billed $10, $20, $30, $40. So there's a huge difference there, and that's a whole nother topic. Direct specialty care is very similar. It's very new, but you see specialists doing this who, have lots of kind of chronic patients. We see this in endocrinology a lot or in rheumatology, where they're seeing these patients frequently, but they're able to divide, to get new patients in very quickly, unlike, a lot of the commercially, clinicked subspecialists. My wife needed to see an endocrinologist, and she had to wait almost a full year to get in and see that provider because there just aren't that many of them. So on the other hand, concierge medicine will bill your insurance company for the services that insurance provides, but then they will also do much more or a lot of additional services as well. You can think of this as, kind of a first-class airline ticket. You're still flying there, but it's a lot more comfortable. So a lot of times these will do, special heart disease screening or bone density scans or dietary recommendations or whatever it may be in the office. Once again, you're getting much more, office visit time. Average office visit is between 45 minutes and an hour. Usually you have same-day appointments or next-day appointments. And with concierge medicine, a lot of times the provider will do actual home visits for you if you're ill at home. Now these typically are billed out as a year at a time. So even if you have to pay one, every month, you still are on kind of a contract, if you will, for an entire year with them. Other potential options are a thing called a health savings account. Now with this, you may still be paying a monthly premium for your insurance, but you're also depositing money into basically a health credit card. And you can use this for any health expense. Like you go to a drugstore, you need some Tylenol, or some ibuprofen or a Band-Aid or whatever. And that HSA card covers any of that. It covers surgery, it covers labs, literally any healthcare cost it will cover. And this can be tax deductible too, depending on your income level. Another option are some of the actual health credit cards. One of the main ones we use in this part of the country is an organization called Care Credit. And this is very similar to a credit card in that you apply for it, and they typically give you a limit based on your credit. But then that is often a 0% interest rate over the next 12 months. So you can pay your $200 bill off all at once, or you can pay it in 6 months or whatever. It's still that $200 amount. So there's lots of options. And, I always ask patients or tell patients, if you're not sure, you can always talk. If you do have commercial insurance, talk with your insurance company, try and figure out ways to kind of help with, offset those costs or submit things. Like submit everything to your insurance company. If it's a healthcare cost and you're not getting it properly reimbursed, submit it. Or if it's medication that they're not covering, there are forms that can be filled out to have your provider kind of talk about what's called medical necessity. So Anyway, I hope you enjoyed this video. If you have any questions, I'm happy to answer that. We'll resume our normal kind of health education discussions next week. But otherwise, I'm Dr. Corey Babb, and I hope you have a wonderful day and a wonderful rest of your week.